You're listening to Medscape's In Discussion series on respiratory syncytial virus in adults, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Forrest Arnold. Dr. Arnold is the chief of the University of Louisville Division of Infectious Diseases and director of the Center of Excellence for Research in Infectious Diseases. He also acts as the co-editor-in-chief for the Journal of Respiratory Infections and program director for the Clinical Fellowship in Infectious Diseases. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Forrest Arnold. Welcome to Season 2 of the Medscape In Discussion podcast series on RSV in adults. Today, we'll discuss epidemiology and the approach to RSV in adults. First, let me introduce my guest, Dr. Angela Branche, Associate Professor of Medicine at the University of Rochester. Part of her research involves population-based studies of RSV infection and the development of vaccine and antiviral agents for RSV. Dr. Branche, welcome to the Medscape In Discussion podcast.
Thank you, Dr. Arnold. Happy to be here.
Great. As we begin to talk about RSV, first tell us where you work and what your job entails.
Sure. So I work at the University of Rochester Medical Center. I'm an adult infectious disease physician, so that's my clinical practice, both inpatient and outpatient, anything related to infectious diseases or HIV medicine. I've been here about 12 years altogether now. And this is Rochester, so we have sort of a longer winter season, which makes it the ideal place to study respiratory viruses. So historically, the University of Rochester has been known for its study of respiratory viruses like influenza, RSV, the subject of our conversation today, human metapneumovirus, coronaviruses, and we've also done a lot of work defining the burden of disease in adults, as well as helping to develop vaccines and therapeutics related to that.
Do you think it's cold weather and people having to be forced together that promotes all those respiratory infections, including RSV, or another factor?
I think it's a lot of indoor exposure and folks hanging out together indoors in environments where they can transmit viruses. And because we have, I like to say 6 months of winter, other people who were born and raised here will disagree with me. But it feels like 6 months of winter. That's a lot of time for people to be indoors transmitting viruses to each other.
Yes, it sure is. So since you're an epidemiologist, why don't you tell us some of the prevalence and impact of RSV infections on adults?
Sure. So RSV infections cause seasonal epidemics in adults and children every year. In most seasons, the incidence is probably similar to influenza, causing as many infections as influenza in adults, which I think is something that's not as well recognized. I would say the annual incidence of RSV causing hospitalizations in adults 60 years and older ranges probably somewhere between 6 and 8%. It causes between 140 to 170 hospitalizations every year. Probably 1 to 2 million medically attended illnesses. Those are illnesses where you'll see your doctor, go to an urgent care, be seen in the emergency room, etc. And anywhere, depending on the estimates you look at, of 10 to about 15,000 deaths in older adults every year, which is not insignificant. So put it in perspective with influenza, you can see anywhere from 10 to, in a very bad flu season, up to 80 or 90,000 deaths due to influenza in all adults, not just older adults. And so RSV causing really very predictable mortality of 10 to 14, 15,000 deaths really every year. And it doesn't change very much, makes it quite significant in this population.
Okay. If you look at the incidence of any respiratory virus, I think people are surprised to hear that we declare that there's an epidemic every year, but there is. And I think you're very correct in saying that. So pre-COVID, and before RSV was very significant in adults, we used to just, in the middle of the epidemic, treat influenza based on clinically and not so much on a test after a while. So how has that changed today with an epidemic? Is there a point at which we can stop testing, or now it's more viruses that test is important with the nasopharyngeal swab?
Yeah, I think unfortunately in the winter seasons, you have more than one viruses and bacteria circulating that can cause respiratory illnesses that require that you see your doctor or be hospitalized, what we call medically attended illnesses. RSV tends to start circulating first, interestingly enough, in the southeast, and then it moves its way up to the northeast, and then it starts to move to the Midwest, and then finally the last place where we see RSV epidemics in communities starting to appear is Northwest. And so by December, we'll have probably the entire country having lots of RSV circulating in their communities, but the timing is slightly different. Flu overlaps with that. Flu tends to be about a month to 6 weeks after you start to see RSV. And so you'll see RSV first, and then you'll see flu appear in your community about 4 to 6 weeks later. There are other viruses. There are coronaviruses. There's human metapneumoviruses. They also overlapped in that same winter season. And so they might be slightly different timing. So maybe December, January might be when you start to see metapneumo appearing and peaking. And coronaviruses are very, very variable. The clinical syndrome of any one of these things in people at risk for severe disease, for bronchitis and pneumonia, and specifically older adults, overlaps as well. So it's really clinically indistinguishable to a treating physician or provider whether what's causing you to be ill is flu versus COVID versus RSV. They all look the same. There's some minor differences, like RSV tends to have less fever and tends to be a very wheezy kind of illness, but by and large, it's really clinically indistinguishable. And so it's really fortunate that we now have good diagnostic testing because you do need to make a diagnosis. You need to make a diagnosis, first of all, so your patient knows what they have. And so they also know what they don't have. Why is that important? Well, things like influenza and COVID, there are antiviral treatments for that. So knowing that it's COVID or flu, you can give Tamiflu, you can give Paxlovid. These things will help decrease the duration of illness and the severity of symptoms. RSV does not have a treatment, but on the other hand, if someone has RSV, you don't want to give them a drug they don't need. And so being able to prescribe the right treatment for the right infection, I think is of critical importance. It also helps you manage your patient's expectations. If there's just something I can do that'll help, great. If there's something I can do that won't help, I need you to know that too. So yeah, these are all really important clinical decision-making tools, which is why we really do stress making that diagnosis whenever you can.
And we've talked on this podcast before about a 3-plex test for influenza, COVID, and RSV. And there's also a multiplex that includes other viruses such as adenovirus and parainfluenza and the metapneumovirus. So what you just said was really important, and I think it's worth repeating. Maybe you could just tell us the consequences of delayed or inaccurate diagnosis.
I'm a respiratory virologist and an infectious disease doctor. I find it so critical and important to be able to tell my patients what I think they have or what a diagnostic test shows. So obviously I'm a fan of using diagnostic tools whenever you can, but I recognize that in practice, some of these tests are expensive. They're not always widely available. And so you really have to think what's going to shift the needle in terms of how I care for my patients. I think that early and timely diagnosis of influenza and SARS-CoV-2 will help you make important treatment decisions. I think early and timely diagnosis of RSV will help you to know how to support your patients, will prevent you from doing things that aren't needed, like getting echocardiograms, getting urine tests, giving antibiotics, giving things that won't help your patient and potentially could actually hurt them. And I think our early diagnosis specifically of RSV will help you with transmission in important settings. So settings like the hospital, nursing homes, adults that go to daycares, even within a home, knowing that you have an RSV infected person, because RSV is so easy to transmit, will actually help you protect others around that infected person.
And how does the epidemiology of RSV in adults differ from that in children?
So kids and adults are the most affected by RSV in terms of severe symptomatic illnesses. So like most respiratory viruses, RSV does tend to cause more severe illness in these extremes of age. Interestingly, the most infections we see in a year nationwide or worldwide is in fact in children 2 years and under. And so it's a major cause of hospitalization in young children. However, the most deaths that we actually see in the United States is in older adults. And so that's why, even though you might not see millions of cases in adults in the United States, the ones you do see, there's a significant risk of mortality that we don't have in young children right now, thankfully. The other thing that's different about these two groups in terms of their illnesses is that they can present differently. Often young babies and toddlers that get infected with RSV, they'll have bronchiolitis, which is a sort of a childhood version of bronchitis, just really severe airway obstruction. They could develop pneumonia. They tend to get acutely ill very quickly. So within a few days, they'll present to your office or the hospital because they're quite sick. Many of them will have fever. And so it's easy to see the impact of RSV early on with children. In adults, it tends to be a little bit more insidious. They might have a cold for 3 or 4 days. And then as it progresses and gets down to the lower respiratory tract and to the lungs and the lower airways, that's when they'll have wheezing, they'll have shortness of breath. If they have underlying chronic medical conditions affecting the heart or the lungs, they'll have exacerbations of those conditions. And so by the time they come to see you, they're probably 5 to 7 days into their illness. And at that point, it's not necessarily how quickly can they clear the virus. It's more what damage has having this viral infection done to their airways and their lungs? What has it exacerbated? How do you manage all those other things?
RSV in both of those populations, children and adults, peaks in the winter, but do the peaks exactly overlap?
I think it starts in children first, typically. So you'll start to see babies being hospitalized or seeing their doctors, probably be about 2 to 3 weeks before you start to see adult infections. And then the peak for babies will tend to be a few weeks earlier than adults. But they're pretty good overlap. For whatever reason, babies and children and school-age children particularly are just sort of the reservoirs for RSV and what sort of starts an epidemic within the community.
Right. So adults should take the increase in RSV in children as a heads up that, hey, they really need to be cautious about the weeks ahead because they'll be more at risk. Actually, what risk factors are we concerned about that might lead to the worst RSV, that is a hospitalization for adults?
Yeah, so we've been studying this here and others have been studying, around the country and the world really. And there's some very specific risk factors that predispose people to more severe RSV disease. They're not unique to RSV. You'll see some of the similar risk factors with influenza and COVID as well. The most well-defined risk factor in adult populations is age. For every decade of life over 60, you basically double the incidence of RSV as you move from 60s to 70s and 70s to 80s. And so for adults in their mid-70s and adults in their 80s, these are probably the best defined and potentially the highest risk groups. And so we tend to recommend universal vaccination in those age groups. For adults in their 50s and 60s, risk is more based on the presence of certain underlying medical conditions. Specifically, chronic cardiac and chronic pulmonary conditions confer some of the higher risks. So things like chronic pulmonary conditions like COPD and asthma have been associated with increased risk of hospitalization, needing oxygen, ending up in the ICU, those sorts of things in adults. And risks that I think are less well appreciated, but may even be more important, are the cardiac risks. RSV has been associated with increased risk of having an acute MI or a heart attack after you have an RSV infection within sort of those first 30 years, maybe as high as 3 times the risk of having that in somebody with heart disease. It's also associated with up to a 20 times increased risk of hospitalization if you have heart failure and you get RSV. So someone with heart failure versus someone without heart failure will have up to 20 times increased risk of being hospitalized if they get infected with RSV. That's an incredible risk factor. And then there are other things that, we're still sort of working to understand and to define, things like diabetes, but mostly poorly controlled diabetes, chronic kidney disease, folks on dialysis, and those sorts of things.
When we consider epidemiology specifically, people are more familiar with the communicability of a pathogen as expressed as R naught. Would you mind reminding us what R naught means and where RSV falls on that scale?
So R naught is really sort of a mathematical model that helps you to understand how transmissible a virus is from person to person within a community. To sort of put that in perspective, measles is probably the most transmissible virus that's ever affected human populations. And I think that had an R naught of something like 10 to 12, which means that for every person that gets a measles infection, they would then go on to transmit to 10 to 12 people. Flu, influenza, so seasonal influenza, has an R naught of somewhere around 1.5, so between 1 and 2. So every person infected with flu will go on and potentially infect 1 or potentially 2 other individuals if they're exposed them to their infection. And then SARS-CoV-2 or COVID has an R naught of somewhere between 2 and 3. So more than flu, but interestingly, not as infectious as RSV, whose R naught is 3. So for every person infected with RSV, they'll go on to infect 3 other individuals. And that's probably because RSV can infect you in a way that many other respiratory viruses can't, including influenza and to some extent SARS-CoV-2, which is that with RSV, you don't just get infected by having somebody sneeze or cough in the air and inhaling those respiratory droplets. With RSV, it's actually in the snotty nose from the kid that you're holding or wiping their nose. It's on the surface that snotty nose kind of landed on or the tissue landed on. And it stays on that surface for a number of hours. And so that's something that influenza can't do. It can't live on surfaces for an extended period of time, whereas RSV is more hardy and it can. And so there's the possibility of transmission by just coming into contact with contaminated surfaces, I think, which is what probably increases that R naught a little bit.
When we think about RSV and epidemics from the healthcare worker perspective, they encounter hospital protocols where they work. They encounter state policies in the state they live in. And then there's national CDC guidelines. What do you recommend to them to process all of these different suggestions coming at them?
I think that's tricky, navigating all of that. I guess I tend to think I would pick 2 of the 3 and not try to synthesize all 3. The most important guidance is what's happening locally. I think that whatever your local state health department or local health department or local institution enacts, that's probably, the first one you should try. They are a little bit different, but they're not so different that I think it'll really have a meaningful impact on transmission. So I would start first with whatever your local institution's guidance is. I think the CDC is a great resource. So that would be my next approach, is to just get a general overview of why policies are what they are. And I think that the CDC offers sort of the best overview and explanation as to why we do certain isolation practices, contact versus droplets versus a combination of both, which is what we do with RSV typically. I think the CDC also has a lot of good resources for healthcare resources around vaccinations and risk factors and how you have conversations about vaccinations with your patients. So that would probably be my second look if I were a healthcare worker and I was sort of confused about all the different recommendations and how they do and don't overlap.
Right. So the local guidelines may have more specific recommendations for the isolation you're talking about or cohorting. And I'm interested in your opinion about cohorting and what you can tell us its role is.
So I think cohorting is a tool that we use to prevent nosocomial transmissions within hospitals and also within other long-term care facilities. I think it's very important. Nursing homes, for example, are a good example of how cohorting does or doesn't work or may or may not be important. When you have a nursing home that does routine testing of respiratory illnesses for influenza and RSV, and they detect RSV, then they can isolate the entire floor. They can start by isolating the room and then the entire floor. They can do screening testing of that floor to see if there's asymptomatic transmission going on. And so that's how cohorting really kind of helps you to protect the spread of the virus within your healthcare system or your institution or your ward or wherever. In the absence of cohorting, of knowing when somebody is asymptomatically transmitting virus or potentially their risk of becoming infected because they're near somebody who's infected, I think what you end up having is sort of a rapid spread of transmission of the virus throughout sort of that area. So throughout the nursing home, throughout the unit that you're talking about. So I think cohorting is sort of one of our best tools of prevention when you have folks sort of confined to certain locations and you know that people will be bringing in viruses. So how do you prevent that transmission? And I think that's one of our strategies.
Okay. As we wrap up today, is there a certain website or place you can recommend healthcare professionals to seek to learn more about RSV diagnosis and management?
Yeah. So again, I really do like to direct people to the CDC. I think the tools there are actually exceptional, and they have tools for healthcare workers. They have tools for patients. And so I would really strongly recommend that folks visit those sites and really make use of those resources for all the questions that they have for everything from disease burden to transmission to surveillance testing to vaccines to treatments to all those questions really are answered in a very detailed way that I think will be helpful.
Thank you. Today, we've heard how important an accurate diagnosis is so that treatment can be directed accordingly and so that treatment for COVID or influenza cannot be used on somebody who doesn't have that respiratory virus. Another important point was that for each decade over 60, it doubles the incidence of RSV risk in patients, and the heart disease increases the risk for hospitalization up to 20 times. Today, we've talked to Dr. Branche about epidemiology and the approach to RSV in adults. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on RSV in adults. This is Dr. Arnold for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Respiratory Syncytial Virus in Adults podcast series with our host, Dr. Forrest Arnold. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on respiratory syncytial virus in adults.